Hi, my friends. A lot of people coming in. Thank you again. It's been really, really great these times. Um, this pandemic times was we have to take some good points about that, right? And the good point is, I think the way we're doing some meetings, the way we're doing some webinars, are really changing the medical education, maybe forever. Okay, of course, we're going to still have the conventional meetings, the regular meetings, but of course, the online programs, the online webinars, we could see that we can really update ourselves doing this kind of events, and from the comfort of our house. That's the good point. We can do, we can learn a lot with the big names and big guys in the world. We can update ourselves and learn techniques from the comfort of our house. Do very nice discussions. Right. This week, I was in a webinar, in a live talk with very good friends here in Brazil, Dr. Pelarin, Dr. Ishida, and Dr. Honshi. And we spent 3 hours talking about rhinoplasty. And until the end, there was a lot of people in the room. They were really excited about talking rhinoplasty. And also in our first lecture of our online mentoring program, which was on Tuesday, was the same thing. We stayed 3 hours talking about rhinoplasty. That just shows how we love what we do. So it's a privilege because not everybody in the world have this privilege to work with something that we really love. And I'm sure that this more than 100 people and a lot of people coming in here, we're all fanatics and we're all rhinoplasty lovers. I think that what makes us really hungry for knowledge, really hungry for these kind of meetings, really hungry for improving ourselves every day. And when we decide that we want to do rhinoplasties, we have to have this kind of mindset because we never it's a never ending process. We have to study and study, and it seems that always you have something to improve. So that's the good point about rhinoplasty. You are always fighting against yourself to improve yourself and to become a better surgeon every day. So that's really amazing, and that makes me really happy. And every time we're doing this kind of rhinoplasty discussions, we have so many people interested, so many people from all over the world, from um, from Japan, Australia, uh, to United States, Canada, Chile, South America, Latin America, Europe, so Africa. It's really amazing. It's really amazing how close we can get with this technology nowadays. All right. Thank you so much, everybody. Thank you. Gracias a todos los amigos de Latinoamérica nuevamente, todos siempre juntos y siempre muy presentes en todas las lives que nosotros hacemos. Entonces, muchas gracias a todos. Hoy tenemos un invitado muy especial, que es el profesor Saban, que seguro que a todos ustedes ya lo conocen. Él es el padre de la rinoplastia del dorso de preservación moderna. Y cuando todos estaban haciendo otro tipo de cirugías, él se mantenía haciendo la preservación del dorso. Entonces, una persona con visión de lo que de la cualidad de la técnica y de lo que podría tener de ventajas en esto. Entonces, hoy tenemos una charla y una live muy especial de tener uno de los grandes cirujanos en el mundo de cirugía de la nariz y que a mí me gusta mucho, me encanta mucho, no solamente la parte profesional de él, pero también eh, la parte personal. Cómo es una persona que consigue ser una persona tan grande, pero con tanta simplicidad. So we're here with people from all over the world. We're about to have Dr. Saban here, and I'm just saying how amazing is Professor Saban with all his knowledge. He's the father of the dorsal preservation, the modern dorsal preservation. He's been doing this for more than 20 years, and he started teaching when nobody was believing so much on this kind of technique. And now considered one of the revolutions of rhinoplasty. So every time, for many years, people doing structural rhinoplasty, which is a very good technique. I'm not saying it's not. It's really good, really good. But also with preservation rhinoplasty, we incorporate something new, something more in our knowledge base, something more in our arsenal to treat patients. So Dr. Saban is really part of the history of this revolution in rhinoplasty. And like I said in Spanish, he's I really admire and I really like the way he's so great and he's so big, such a big name in rhinoplasty with such simplicity. So he's an example not only for me, but for everybody of somebody who is a master in something, but keep his uh, the way he's really is inside. So that's really amazing. All right. So people from Croatia, Mexico, yeah. Thank you so much. Morocco, yeah, Fortaleza, Brazil, Colombia, yeah, many people. Great, thank you so much. Oh, more than 200 people here. Yeah. So I'm going to invite Dr. Saban to join us now, and we can start talking to him and learning a lot from him. Okay, let's go there. All right, Professor Saban. Oh,
Hello.
there you go.
Hello. Hello, Fernando. I'm very grateful. You know, the one thing is, French is so close to Portuguese or Spanish that when you are speaking Portuguese, I can understand what you are saying. So
Oh, really?
yes. So I felt like very proud of your words. So thank you very much. I do appreciate. First of all, I do appreciate the invitation, and then now I feel honored with the words also. So thank you very much for everything. So it's
Oh,
it's a
yeah.
great pleasure. Thank you very much for Preface, and you are doing a great job. Oh, I will say that like a conclusion, not as starting.
Okay, okay. Yeah, but thank you, Dr. Saban. Thank you. I know you're doing a lot of work on these days. You're writing a lot of papers, writing the third edition of the book, and a lot of webinars. And you separate the time here to share with us. Here we have a lot of Brazilian fans of you, and a lot of people from Latin America also. And in my point of view, preservation is really a kind of revolution in rhinoplasty because not because it's gonna uh, uh, take the place of structural rhinoplasty, but the opposite is gonna put something together and put one more possibility to treat the nose, and it's really spread in Europe, Turkey, in some places, in some countries in Europe, but not so spread here in Latin America. A lot of ENTs here are doing for such a long time, but plastic surgeons not doing such for such a long time the way you do. So I think it's really important what you have to say today, and people will understand a little bit more your concepts, a little bit about your history and everything. So thank you again. Merci beaucoup.
Merci beaucoup. Well, thank you, Fernando. So you are the master. I will follow.
Okay, so we separated here some topics to talk
Yes.
and to learn more. I always say, Professor Saban, that when we go to meetings, we don't have this time, okay, to talk to you and really understand the way you think, what made you um, keep believing in dorsal preservation for so many years. You've been doing that for more than 20 years. And I wish you could speak a little bit about this history of preservation rhinoplasty to start our talk.
Thank you very much, Fernando. Thank you very much. Do you see my screen now?
I'm going to share it. Yes, it's it.
Yes, that's fine. So thank you very much. Yes, history is important. It's very interesting as well, because of course, it is not new. I have a few. Maybe I can start to show a few slides, and I will talk about that, because I have always to say that. In fact, I have a triple certification: facial plastic, maxillofacial, and DMT. Some disclosures. These are my disclosures. Just to say that I started rhinoplasty. It's not new story. I started rhinoplasty. This is my medical thesis. It was in 1984. It means that it's 34 years ago. I started with rhinoplasty already. And so it was very important in my life, starting with that. And then second thing is this. I was always from rhinoplasty to facial anatomy and back to rhinoplasty and back to the anatomy. This is my life. This is the first book published in 94 in facial anatomy, then a second one 15 years after, and the new one more recently. So it means that to perform in a good way rhinoplasty, you need also to know very well the anatomy. And I have been lucky being able to do both works. And I would not be too long, but just to remind this, because it is important, I think, that rhinoplasty, there are three situations: primary, revision, reconstruction. That are three different situations. We say revision generally we say revision for our own cases, and we are talking about secondary rhinoplasty when they are coming from elsewhere. But in practice, it is the same. Sometimes we say also touch-up. It's like to make the revision like something very easy and light. And there are two approaches: close or open. It's not a debate. I think it's not a big problem, not an issue. Philosophies are important, and the story of the rhinoplasty is following this. Resection is we remove the dorsum. This is Joseph. And Joseph was with Rowe, and they were very at the end of the 19th century working on that. Structure is more recent, mainly developed by Dean Toriumi. You have already invited him, and he is really a fantastic surgeon and a big thinker. And preservation, that is also not a new story. I will talk about a little bit more about that. The concept of preservation consists in preserving. This is due to Roland Daniel. It is his diagram. You can preserve the dorsum. You can preserve the alar cartilage, lower lateral cartilage, and you can also preserve the soft tissue envelope. And this, when you cross all these possibilities, it gives you what can be preservation. People think that preservation is to preserve everything. I mean, the center point of this diagram, but you can preserve many things. What is important in preservation is to understand that it is a philosophy. It is not one technique. There is not one single technique for preservation. There are different techniques, but the philosophy is different. When you are performing resection, you are starting saying, okay, I have a hump, I have to remove the hump. So you are thinking about how much you will have to remove and how you will remove. When you are performing a structural rhinoplasty, you are thinking about, okay, what kind of grafts I will have to put: a spreader graft, a sandwich, graft here, and septal extension graft, or whatever. When you are thinking preservation, it's the opposite. You are starting thinking, what can I preserve and how far I can preserve the structure. So this is not only a difference of techniques, it is also a difference of philosophy. And of course, we have to know all of these different philosophies because techniques are depending on the philosophy. The history, few words. History of key area preservation. Septal strip, first described by Goodale. Goodale was in Boston. He published the first paper on preservation with the high strip, and it was very interesting because in his paper, he's already saying most of the things, like where do you perform the osteotomies, how to remove the strip, and so on. He was followed by many surgeons, French ones, many French ones, Morel before the beginning of Second World War. And I was resident in Gola. He was head of maxillofacial surgery. I was performing also learning maxillofacial. And but he didn't start at this time. He started later when I was no more resident. And he told me, you should be interested in my technique and so on. Okay, so I went then and I started really working on this and publishing in this early 21st century. On the opposite, good day, removing a high strip. On the opposite side, there is the disarticulation, septal. Septal disarticulation means that you have to divide vertically the septum, and then you have to completely separate both micropericordium envelope, and then you are able to make mobilization of the septum, completely separated from the bony framework, and doing that, you can lower the septum. Then there have been many followers using Kern, Lopez Infante in Mexico, Vayoff in France, Lucetti in Italy, Davis in Brazil. But Ishida is of course, Ishida, because he published his paper on dorsal disarticulation in 1999. But it was mainly the same philosophy than this one. It means that he had to separate the septum and to preserve the cartilaginous vault. He was, I think, the first really performing cartilaginous pushdown and preservation. And this is just to show you what my personal journey. Okay, to be quick, I started with, all the techniques, Sheen, Peck, Johnson, Torimi, and I was organizing, beside that, a lot of courses of anatomy and surgery. But what was important is this. The revolution starts in 2012. I mean, the revolution of when we started popularizing the preservation rhinoplasty. It started here. About 8 years ago, a brainstorming group with Miloš Kovačević, Olivier Jabot, Goxel, Charles East was born in Europe. And very quickly, we were also with Roland Daniel, Rick Davis, and then Baris Chakir. I met Baris Chakir in Budapest. At this point, Jabot was very important, because in Budapest 3 years ago, he told us, okay, I would like to try to make new inserts for the piezo. So invited in Peter Parazzi Anatomy Lab, Baris Chakir, me, and we were with him. And then I could show to Baris Chakir what is preservation. And then he understood the power of this technique. And he is very clever, very smart, open mind. And then he started almost immediately after. And then he talked with Roland Daniel, and then the history started. And then we could publish this paper about revolution. So I'm not the one who invented the technique. I was just the one, after more than 20 years experience, having the chance of being able to publish and make diffusion of the technique. This was what happened in more details. But I can tell you that life has not been always easy, because I have had, as you can imagine, a lot of problems with my colleagues. And what I could meet was this: at least they were indifferent, no interest about what I'm doing. Many times criticism, okay, you're doing that, but it doesn't work. We know that it does not work. Sometimes aggressive, oh, this is a dangerous technique. You should not do that. You never know what can happen. But most of the time, nobody has been never interested in the technique. So I would like to say that thinking differently is a difficult task, and sometimes it needs time. And because not following the flow is really risky. So this you have to prove. And we published this paper a few years ago, 3-4 years ago, about my experience in dorsal preservation. And you know this paper, so I will not emphasize this. So now we can go back with you. This was the short history.
Yes, that's so interesting, Professor Saban, because I think the first time I went to the preservation meeting in Nice, I saw you guys so emotional because of that. Because it seems like that it's a meeting that was bringing to the rhinoplasty world something that was like kind of hidden, and people were not giving so much attention to that. And I felt that energy there, and I thought it was really really nice to share with people here. Um, because it's like you said, if you do the same thing everybody are doing, you're of course you're gonna have the same result. But when you put your mind in a different way and you start doing something different, or trying to go for a way different than everybody, then you have the chance to do something different. And I think you were one of these guys that you believed on the technique, you kept doing that for more than 20 years, and you fought all these kind of bad situations, but now it's really considered a revolution in the rhinoplasty. It's so nice to see.
It was good to wait. I mean, but what I wanted to say, it was not bad time for me. It was interesting. I said, okay, they don't want, they are not interested, but so bad for them, not for me, because I was still doing. I was convinced that it was working. Because, but in my story, as you have seen on the screen, I started with really with following Sheen, and then slowly I moved to the open, tried the structure, and at the end I said, okay, we have issues with all the techniques, or it becomes too much difficult. Don't repeat that. We don't know who is listening, but don't repeat that. I was a little bit upset with the meetings where you spend 12 hours for 5 days learning about how to graft, where to graft. And I was, at the end of the 4 days, I didn't remember anything because I was absolutely confused. I didn't know what graft in which situation, where to put it, and so on. So I said, we have to go back to something simple and try to keep simple. That is not always easy.
Yeah, and I remember myself, even if we talk like 3 years ago, uh, when it was not so popular like nowadays, I remember that I was in a meeting and you were speaking about preservation, and there was not so many people interested in that. And I went to the room and was not full. The other room of structural rhinoplasty was full. And but when I saw your presentation, I was thinking that, wow, this is so nice, and I want to learn that. So I saw you doing that preservation thing and preserving all the key area where we can have some irregularities because of scar tissue. And on that time, I really focused on learning that, and I own that. The click for me was your lecture around 3 years ago.
I would like just to point out something. I mean, with preservation, we cannot say that the global issues are better than the others. I mean, we don't have the percentage of revisions probably is the same, but what is different is that the procedure is much simple, and the revisions are really very different. I'm checking my last 400. I'm writing a paper on that. My last 400, exactly 332 cases out of the 2 years experience of my last cases, and I measured the time of the duration of the revisions. The mean, the range is 23 minutes for revisions with after preservation. When you are performing open structure and you have to do revision or secondary, depending on who is doing, it's much more long. Even in my hands, it takes between 2 and 5 hours. It's not the same.
Yeah, I did a quick research in my own cases, and and it proves exactly what you said. Before doing preservation, my rate of revisions was around 10-12% in primary cases. But after learning preservation, the first 50 cases, I had, of course, a higher incidence of revisions because I was in my learning process. But after that, I did another research in my own cases, and it dropped for 8-10%. So basically the same rate of revisions. Yes. But different is how complex are the revisions, and that you're totally right. In my own practice, my revisions, my primary surgeries, they dropped the time of my surgery. They dropped 23% in time. So I'm 23% faster than I was before, and also my revisions are so quick because I have the cartilage preserved, and sometimes I just have to do some small rest or some small fillings, and it's really life changing for
I think it is
somebody who
one
learns.
of yes, it is one of the main strong points of this technique and philosophy. I like to talk about technique, but it's also the philosophy is important. Don't forget,
Yeah.
we want to try to preserve as far the nature.
Yes, that's it. So, Professor Saban, we have here a lot of people in the learning process, okay? Because,
Yes.
like I said, we see, of course, many residents and people who finished their training 5 years ago, and they are really focused on learning preservation. But we also have some groups of senior surgeons who kept doing some other techniques, and now they're really interested in that. So preservation makes a revolution in structural rhinoplasty guys because they want to be less invasive. In the senior guys who are doing like reduction rhinoplasties or closed approach, they say, "Oh, good thing because something of closed approach came back," and they're excited about that. And the younger people are all excited also because they're learning that. So talk to us a little bit about this teaching and learning process. How do you think someone should start learning preservation? From which part and with which kind of technique? How do you think about that?
It's very important and very interesting question. What was nice at the beginning is to see my friends, I mean, who are in the same group, IRES, Milos Kovacevic, Charles East, Olivier Jabot, even, and the others who were Roy Daniel, all of them were performing open structural rhinoplasty. And for them to switch to, not all, but at least partially, to the preservation was really a big journey for them too. And it was interesting to see how colleagues, friends performing open structure could switch to open preservation and sometimes to closed preservation. But the way is not the same for everybody. As you said very nicely, depending on if you are a beginner or if you're already an expert in surgery, in rhinoplasty, the way is not the same. But what I like to say to the very experienced surgeons in rhinoplasty, don't commit the sin of pride. The pride is the enemy of improving, open mind, and trying to offer better results, changing what we are thinking and doing. This is important. And in rhinoplasty we have many. Okay, okay. So now let's
Yeah.
go with this. Okay, so I will talk about this: teaching,
Okay.
learning, preservation. Okay, just a few words. Before starting performing, you have to understand the philosophy. You know that we have talked about that. The philosophy is to preserve the dorsum when it is good. Right? If not good, you cannot preserve. You have to check your anatomy knowledge. Not everybody, many people, I was surprised to see that many surgeons don't even know correctly the anatomy of the nose. And I said the biomechanic. Biomechanic is what is happening when you are removing or when you are pushing on a segment of the nose, what will happen not only on this segment, but on the adjacent segments. I mean, for example, you are pushing down the dorsum, then it changes the shape of the nostrils, the orientation of the tip, and so on. So the biomechanic is important. And that will explain to you that for the beginners, for example, if the tip is nice, you don't need to perform any procedure on the tip. Just lower the dorsum and the surgery is finished many times. Or in straight deviated nose, the same. I can show maybe some pictures about that. And of course, you have to learn the basic principles and to choose the correct patient. So if you are really a beginner in rhinoplasty, you have not done any rhinoplasty, you have to know at least how to perform a septoplasty and turbinoplasty, because you cannot perform rhinoplasty if you are not able to improve the breathing of the patient. And you have to go to the anatomy lab. Yes, you can interrupt me whenever you want.
Yeah, no, I think, are you sharing your screen?
Yes. Oh, it doesn't work. Oh, I'm sorry.
Yeah.
I'm sorry. I was speaking and showing my slides, but I thought, okay, so let's go. Let's do it again. I'm sorry, really. Share the screen. Partager. Here. Partager. Yes.
Yeah, that's great. Now that's okay.
I apologize for my mistake.
No problem.
So just to show you, but there was nothing interesting before. It was just this. So if you are a beginner, you have to start with the beginning. So the basic are septoplasty, turbinoplasty, and going to the anatomy lab. You cannot start with the preservation if you are not at least have done once the preservation on dissection table, and you have to see what is doing in life surgery. You have courses for that. You can, and Fernando, I know you have traveled a lot for improving and knowing and learning the preservation. You're across all the continents, transcontinental. You are a transcontinental surgeon, and it is this is probably one of the best way to learn is to see the surgeons. And then you have to perform really step by steps, not doing all the steps at the first time, but really a step, start with the approach, then start with the septum, then go on incrementally, really step by step. Observe the patient and go back to the lab. If you are going to the lab at every step of your learning curve, then you will improve very quickly. Otherwise, it will be longer. On the opposite side, if you're an experienced surgeon, and I told you many of my very good friends, very experienced surgeons, it was not easy for them, even if they didn't commit the sin of pride. But anyway, it's difficult. So you have to, we have published a book. I think the book has not been, we didn't do the book for getting any money. It was really for teaching, because we didn't want our colleagues and friends making errors, failures, and being disappointing with surgery. So that's why we did this book. We started 3 years ago. Assist, go to the lab. Even if you are expert, go to the lab, then choose the appropriate patient. We see that afterwards. And again, each step incrementally, and perform, because it is new, the radix osteotomy and how to feel the mobilization of the nose. You should be able to perform a complete mobilization of the nose. I mean, feel like the nose is moving in between your hands. It's very special feeling, this. And also from our friends, Jean Tardy was always repeating that rhinoplasty surgeon never graduates. So we have to stay very humble in front of rhinoplasty. The surgical sequences, that this is a journey generally, anesthesia, endonasal, always from depth to surface, turbinates, then septum, dorsum, supratip, tip, nostrils, and lala base, gendis. This is the general surgical sequence I'm following for all my patients. Just to underline that I always start with the septum and dorsum, and I perform tip surgery at the end. Not at the end, but after the dorsum. Why? Because when you are changing your dorsum, the tip is changing its position, its rotation, and even sometimes the shape. So it's important to start with the dorsum, because if you perform a perfect tip before the dorsum, then when you will perform dorsum, it will change your tip, and you will have to restart your tip surgery. So it's not nice. Start with the dorsum and then go to the tip. And at the end, you can check the nostrils. Sometimes, as you are lowering the dorsum, the tip sometimes lowers a little bit, and you can have nostrils flaring. And sometimes it's good in these cases to resect part of the nostrils, the alar base. And just to remind the 10 steps sequence in the dorsum surgery, there are 10 steps. Better to remind them and try to avoid, except the first one maybe, try to avoid skipping one step, because if you skip one step, you may be in trouble afterwards. The only thing that is I had put in parentheses is the first one, because in straight noses, we don't need to separate to elevate the soft tissues. We can go directly on the septum. Otherwise, it's good to follow this sequence. I think that in the audience, many of our friends and colleagues can make screenshots so they can find this afterwards again without any problem. So take-home message for preservation and learning. First, don't be desperated or disappointed if the first surgery doesn't work, because all of us, we have failures, and sometimes it is the first one, sometimes it is after 10. So when it is after 10 surgeries, okay. But if it is the first one, then you are in doubt and you don't want to try again. So this is important to know. Preservation is good, but you have to learn also the other techniques, because sometimes you will have to switch from preservation to resection and sometimes to structure. So you have to know all the techniques. There are good indications for preservation, and there are also bad indications for the other techniques. And this is how to improve the skill, analyze your results. It's what I'm doing nowadays I told you, for my 332 patients, preservation. Follow your patients, go to courses, and talk and share. And it is what you are doing today, Fernando. Congratulations for that. We have to talk and we have to share with our colleagues. You cannot say you are a master if you are not sharing anything. So this is just basically some things, just to remind: learn, practice, learn, practice, learn, practice, and so on. This is the learning curve of rhinoplasty, is this one, and it is a mix between the anatomy knowledge and dissection, of course, surgical procedure, and of course a small piece of art inside. Okay, I have finished with this talk.
Yeah. Yeah, so great, Professor Saban. It's a sequence, it's a logical sequence in the learning process. And like you said, we have to leave our comfort zone in the beginning and struggle with some learning process, especially people who are already comfortable with good results in structural rhinoplasty. But you were known for preservation rhinoplasty, but you saw that in your presentation, you said you have to know all the techniques. You have to know how to switch from one to another. And that's the main point for rhinoplasty surgery, right? You have to have a good knowledge base to know how to switch and how to use it whenever you want or whenever you need it.
Important, because what we call experienced surgeons, masters already structure or resection or both of them, and they just need to understand better what is preservation. But for the beginners, the way is much longer, because you have to learn all the techniques, so it's not easy. So maybe start with, I would not like to say that start with preservation. I think it's not better. I think the best is to start probably with resection and structure, some grafts like spread graft, and then move gently with preservation. Otherwise, if you have a problem while you are performing preservation, you will have no way to adapt intraoperatively your surgery.
Okay, so you think it's better to, when we teach somebody, it's better to start with open approach structure, and with a little bit more experience, go switching to some preservation techniques.
Maybe, I think so. It allows for better understanding the anatomy and what is happening in the nose. But I would like to say not too difficult. I would like to say basic structural rhinoplasty. Don't try to do all the different kind of grafts on the tip, otherwise you will be lost very quickly. Try to understand the main streams, and this is the responsibility of our friends doing structure, to explain what are the basic steps, what is important to know, and then we can move to some more refinements in the structural rhinoplasty. I don't hear this many times.
Yeah. You know, that's a very nice point that you talk. I, as a learner, okay, every time when I was on the beginning, I was going to the meetings, and you go there and you see some masters speaking about something very specific in rhinoplasty, and that maneuver is difficult, and he has 10 minutes to speak. So you leave the meeting excited because it's something very nice, but you cannot reproduce that because they didn't really teach, they just show something. And this kind of live talks that we're doing today, uh, you really have time to learn from you, for example. And that's a very nice way to really learn, because we have one person, we focus on your philosophies, we focus on your techniques, and you really can teach us. So thank you for that.
Thank you for giving the opportunity.
Yeah. And Professor Saban, let's talk also about some selection of patients. Okay.
Sure.
Um,
Sure.
when we're in Turkey, or when we're talking to Dr. Baris Chakir, as he always um, compare with some patients from other countries. Of course, you go there, you have strong cartilage patients, not so thick skin, and reduction rhinoplasties. But when you come to some parts of Europe and Latin America, you have a lot of Latinosis with some S-shaped dorsum. You have some weak cartilage, thick skin, and how do you think it's a good way for this fluxogram or this sequence to decide which patient is good for preservation or not?
This is difficult because in Nice is on the Mediterranean Sea. France is is really eastern part, and occidental part is western part of the or Europe, but it's eastern like. And we have a lot of different patients, but mostly with, I would like to say, not the most difficult cases, because they have but not too big generally. They have normal cartilages, so dealing with them is not that difficult. Even if in France we have a very broad kind of people living here. And in Brazil, and mestizo nose, or it's very different. I mean, because if you have weak cartilages, strong noses, they are not always the good candidates for preservation. It's not easy to start with this kind of nose. I would like to say start with a more straighter nose. It's better. But I will talk about. I will show how to choose a patient. Maybe I can switch if you agree to show the basic. But if you are from Brazil and you need to perform preservation, or at least the philosophy, many times you will have to. If you have to choose, I will show that afterwards about the dorsum. But the tip, you need to give support to the tip many times. So I know that in mestizo nose, you need to support and give projection to the tip many times, and all the cartilages are pretty weak. I know that many of my friends use at least a columnar strut and sometimes septal extension graft. That's why I said also it's good to start with some knowledge in structural rhinoplasty, because you need to know how to perform some structure in some noses. For example, if you have I will show a case, very strong dorsum, very high, very kyphotic nose, and weak cartilages, you are in trouble with preservation. It's not easy. Then
Yeah.
don't start with this kind of patient, otherwise you are dead. Okay, let's start to share the screen.
Yeah, while you take your presentation, in my practice here, I do much more preservation in dorsum,
Mhm.
because um, not only using the total preservation like you do, because sometimes it's so S-shaped and low radix, but unifying your technique and SPQR and the technique, we have a broad uh, indication for dorsal preservation in our patients, but not so much in the tip, because a lot of weak cartilage, and yes, and sometimes you have to structure, but dorsal preservation we can apply in many cases.
Sure, I think so. I think so. So maybe now I can try to. So do you have my screen now?
Yeah, yeah,
Yes. Okay. So I can show my presentation. Is it good now?
yeah.
Because
That's good.
otherwise I was starting with talking with all the slides. So no,
Nothing.
so this was what I started. There's some preservation in primary. This is a very long topic, so I will maybe be quick on some places.
All right.
Okay, this is what you have to focus on. It is important. Always check your patient in the best way before. Otherwise, it's not easy. You have to choose. Is the first question, is the patient a good candidate for preservation? Second question will be, is the tip mandatory? And then you have to assess the septum, piriform aperture, profile of the patient, for example, chin. So many times I'm performing cone beam examination to check the bones and all of these situations, and also, of course, make computer simulation. I can tell you that I spend always, for the patient I see for the first time, 1 hour with them to perform all this in the best way possible, because many times you cannot see patients 3 times. Some ones are coming from far. So it's important to be able to finish and really to suggest something. So the 2 key questions when I have a patient, can I keep this dorsum intact or very close to be intact, and is the tip difficult? If the dorsum is nice, I mean in front view and sometimes profile, but mainly in front view, I will try preservation. But if in front view the nose is really not nice, I know that I will have to resect. And the next question about the dorsum is, okay, we have to make the difference between the bony dorsum and the cartilaginous dorsum. And then it will decide if you will perform a full preservation, dorsum preservation, or if you will perform a hybrid technique with bony resection and cartilaginous push down. So this gives you the keys of the decision. And then the second question is the tip difficult? If the tip is difficult, okay, let's do it open. But if the tip is easy or even sometimes very nice, do it closed. Don't touch the tip. So this is important to start. So the 2 first questions, can I keep the dorsum intact? Is the tip difficult? 2 main questions. I would like to share this with you. Analysis of the dorsum, front view and profile. Front view, you know how to evaluate this, but you have to evaluate. I will show you better afterwards, but this is a patient operated. In front view, what is important? The nose is not important. Forget the nose. What is important in front view is the look and the smile. The nose belongs to the look with the upper third, let's say mid-third, while the lower third of the nose is belonging to the smile. So in communication, the nose does not exist. There is only the look and the smile. So this is at the post-op 2 years after. What we see is only that the look and the smile are improved. We don't see the nose has been done. And this is what we should be able to achieve with the rhinoplasty. On the profile, yesterday I was hearing José Carlos Neves, very nice talk. Really, I told him it was a brilliant talk. And we are doing things exactly with the same analysis. There are 3 different parts in the dorsum. I will not talk about the tip today. There are 3 parts in the dorsum. We have the radix area. We have the key area that is a mix of bony dorsum and upper part of the upper lateral cartilages. And there is the supratip. We are able to change separately the radix, the key area, and the supratip. So with preservation, we are able to decide what to do on which area. And this is very important. For example, if you make a drawing on this patient, I want to keep and to lower a little bit the radix. I want to remove this height of the dorsum, let's say 6 millimeters, because this line is a bit too high. I want to keep the tip correct, and I need to lower a little bit the supratip. So this is my surgical plan is already done. I have to do this. Then after I have to know how to perform that. So this is her post-op. This is not simulation. This is the truth. This is her post-op photo with the same line. And you can see that 3 years after, she has almost a perfect profile, exactly what has been playing before the surgery. This is a young lady. She is 15 years old. She's a teen. She's coming with this nose before, front view, profile view. She's coming with her parents. Okay, it's not time to talk about teenagers, but let's say all the lights were green for surgery. It is true that she has a harm. She didn't live well. This is the photos, the simulation done with, I do personally with Photoshop. I have of course, no royalties from that, but because it is easy. So there is no 0 millimeter at the radix. I don't want to lower the radix. 4 millimeter lowering the keystone area, 2 millimeter lowering the supratip area, a little bit tip rotation. So this was the pre-op, this is the post-op, almost no change in the front view. And you can see that the dorsum is almost perfect because nothing has been done. While on the profile view, you can see that what we plan to do has been achieved because we are able to anticipate the changement of the patient. So this is the same patient I would like to share with you. This is the first I show you in front view. This is 5 days post-op and more after. Profile view, three-quarter view. What is changing is the look and the smile. Then we don't see the nose in communication. We see the nose only on profile view. Case 2, you have seen her as well. This is front view. The nose is thinner. Profile, three-quarter view, and basal view. You see that we have done also the tip because it was mandatory to change, but she was good. So how to decide? You know, in France, always also in Brazil, you have to choose the good wine for the good during the good dinner. So you have, this is not easy to decide. And then you know the anatomy. I will go quickly on that because you know that. But look at this. Look at this. This is the normal shape of the dorsum. It is not. It is not sheen lines from brow tip. No, the lines. No, the natural nose is like this. It is. I forget, fusiform shape. Look at this, and this is fusiform shape. This is a normal shape. So if you are intraoperatively changing this fusiform shape for parallel lines, you are not achieving a normal natural nose, even nice. And in profile view, just to remind you the different part of the nose. So a second thing to evaluate is what we can call the width. This is what Jankowski, who is a very nice friend of mine in Nancy, in France, he called this nasal parentheses. These are nasal parentheses. And the dissection has been done by Peter Palazzi. This is the fusiform shape of the dorsum, and these are the nasal parentheses. This gives you the width of the bony base of the nose. And sometimes you will have to deal with that and to make it narrow, and it's part of the evaluation of the patient. So patient selection is essential. Let's go on. Oh, I'm sorry, I have to go quickly. Okay, this was good. When you have analyzed your patient, we have seen the basics. We have 4 different types. This is confusing. Don't remind this, just make a screenshot, and we will have time afterwards to talk about that. But the best indications are type 1 and the worst type 4. And you will see that it is not difficult. Type 1 is, let's say, a straight nose. I will show you. This is a straight nose. This is a straight nose. Don't look at the tip position. The nose here is straight. The nose here is straight. The tip is different. So they are generally V-shaped nasal bones. Okay. The nose can be deviated. It is not an issue. And then in this case, you can perform closed roof rhinoplasty without skin undermining. Look at this. This is pre-op photo, intraoperative pre-op photo, intraoperative result. And this was the computer simulation. You can see that computer simulation, intraoperative result are almost the same. Of course, it will change a little bit in the post-op, but you can achieve what you plan to do. And what is interesting is that there is predictability and there is really a low-risk surgery, because in this case, no dorsum skin undermining, no undermining of the dorsum, just working on the septum, performing osteotomies, and adapting the tip. So it's a very quick procedure. This is her before, and this is her after, exactly the same lady. We don't see the nose has been done, even a little bit deviated on the left, even if whatever. She is almost perfect post-op, and she's very nice. And what has been done, look at this. This is her before and after. This is her cone beam before. This is her cone beam after. Look closely. This is the osteotomy of the radix, almost no lowering in this case. The dark space here corresponds to what has been removed to be able to lower the dorsum. As you can see, the shape of the dorsum here is straight, while here there was a hump. Type 2, it is typical tension nose. Tension nose, this is interesting, or deviated with small humps. In this case, if you don't do any reshaping of the nasal bones, you will be in trouble, because it can you can have or the remnant or recurrent hump, or you can have some issues with the bones. So it takes 5 minutes just to undermine the soft tissues and to reshape the nasal bones. So it is quick. Look, this has been published. This is tension nose. This is her in the post-op period. You can see that it is absolutely normal nose and face. I perform also in this case alar base reduction because it was too wide at the end of the surgery, but it is not visible. This is deviated nose. She has nice dorsum lines, but deviated, C-shaped deviation on the right side. Just tilt the nose on the left side. No tip surgery, strictly endonasal. I can tell you no tip surgery, so only septal approach, rasping a little bit, right osteotomies on the right side, osteotomies plus periosteal undermining to free a space for tilting the nose on the left. And this is done. It takes 30 minutes, and you have really, I'm not kidding, it's really 30 minutes procedure, and you have almost a perfect result. Look, the hump has been erased, and it looks like a natural nose. These are very good cases for preservation. This is her in the post-op, even if the combing is inverted. This is the radix osteotomy. This is the transverse osteotomies. And this is the overlap laterally between the nasal bones or frontal process of the maxilla and the remnant of process. You can see that we are not really reducing the width because we are still higher than the level of the inferior turbinate. And this gives you the opportunity to understand that what means tilting. Look on this side and compare to this side. And then you understand that the overlap here between the bones on the both sides gives you a stabilization of your movement, and as well as the lowering of tilting part. And this is the radix osteotomy in her case. Let's move. Fernando, maybe you have questions, or because I don't check the time. Is it correct, or we are late, or?
No, we're good. We're good. You can.
Good. So we're going. Thank you very much, Fernando. We are going to more difficult cases. This is difficult. This is difficult. This is not the same. This is two teenagers. She is 16. She is 17. Two teenagers. Look, if she were my daughter, probably I will operate them, because for sure it's not nice, and they don't feel good with this kind of nose. But it is not easy, because how to preserve this kind of very convex key area? This is very difficult to preserve, because even if you lower it, it will stay convex. So we have a smaller hump, but we will still have a hump. So in this case, you have to perform what we can call semi-open roof technique, or you can perform what we can call cartilaginous push down, or cartilaginous only lowering, or whatever the technique, or hybrid technique. The names are changing, but the philosophy and the technique is the same. You have to remove at least the bones here, so you will have an open roof at the level of the bony dorsum, and you will have, look at this is straight. Why should I remove some cartilage here? No need to remove, just lower. So I can lower the cartilage and remove the bones. Then this is more difficult. In this case, if you are not expert, it's very difficult. She has a post-traumatic nose. She is also 17 years old. She has an S-shaped deviation, but the cartilage is not bad. So I told her, okay, look, I will try to preserve the cartilage, but for sure I will have to remove the bones. Even with piezo, I don't use piezo, but even with the piezo, it's not easy to reshape this kind of nose. And then I will show you the results. This one wanted a straight dorsum. So it is what has been achieved, with always very nice and straight. I'm sorry, my pictures are always bad. My very good friends, I have a lot of friends in Turkey. They always say to me, Yves, you are an excellent surgeon, but you are the worst photographer we know. So whatever. So it's true that I should do it better, but I just for the story, I bought a 2,500 euros fantastic camera for making photographs, and 2 days after they broke my car to steal my camera, so I went back to a simple one. This is the truth. So look at this. This lady, also 17 years old, bony cap resection and cartilaginous push down. Cartilaginous, not sure. Look at the septum. I will show you her CT scan. This is what we plan to perform. Look at her CT scan. Even if you are not ENT, no worry. Look at this. This is front view. This is oblique view. You have concha bullosa. You have deviation of the perpendicular plate. There is a double fracture on the right, then on the left. And then you can understand it's not an easy procedure. So I told her, look, I will do my best to preserve. This is intraoperatively the result. I said, wow, I'm a very strong surgeon. Look at this result. I'm very proud of that. Straight, very nice lines. I said, okay, but look, 1 year after, not as good, little bit deviation. But she's more than happy because she told me, doctor, I'm very happy because you have removed my problems. And she can breathe. She looks like normal. She's happy with that. And type 4, I will be very quick. It is all the cases you are not able to put in the class type 1 or 2 or 3. It is not a straight nose. It is not a tension nose. It is not even cartilaginous push down possible. So we have to remove everything. Then you have to go to the classic open roof rhinoplasty and probably a structure to make her in a good way. I would just like to emphasize that if you are starting with a preservation and intraoperative you have problems, you can always switch from preservation to bony cap resection and keep the cartilage. It doesn't work. Then you can make division between the septum and the upper lats, and then you are performing what I call a sequential rhinoplasty, and you are not breaking bridges between preservation and revision and resection and even structure. But in my hands, it happened very rarely, maybe 10 cases in my life. So because generally we can solve all the problems. Indications, contraindications. I like to say that the best indications for preservation should correspond to the worst indications for resection. Straight nose. Why to resect a straight nose? Just make it lower. Excellent for preservation, very bad for resection. On the opposite, you have seen the last case. The best indications for resection, the last case, step 4, are the worst for preservation. So there is no war. The war is not really existing. It's just problems of indications at the, let's say, at the type 3 patients. When they are distorted a little bit, okay. Then it is our choice but we have always to think that we have to balance the benefit-risk ratio. This is important. We cannot spend 5 hours on a tension nose. It is not allowed to do that. You have a tension nose, you should preserve it and make it smaller, thinner, lower, but without any aggressive surgery. This was my main message. And this I have taken this from Goxel, one of my very best friends. For a good start, just going back to this, male patient, because even if there is still a small hump, they don't complain. Dorsal lines are good. Straight nose, because it is the best indication for preservation and the worst for resection. The septum should be not too difficult. And if the radix is a little bit high, it's even better. So the aims are these ones. But you need to master always septum. Remember, you need to master the septum. It is important, and understand how it works. Fernando, your turn now.
Yeah,
I stop here because time is running. But what I want just to remind this is this: time of revision, 5:23 minutes. Range is 33 minutes in my hands. But frustrations, we cannot do this to all our patients. Bony stabilization is not always easy. And always check this part, piriform puncture and nostril flaring. So,
yeah,
Fernando,
yeah, great, Dr. Saban. A lot of wonderful and natural cases, amazing results with being less invasive. I think that's the key point of preservation. You can do the same thing, you can reach the same good results, but being less invasive, less traumatic, and less complications, less complex complications. So that's really, really nice. Yeah, and we don't, like I said before, we never have this opportunity in a meeting to watch you teaching us for more than 1 hour without stopping, and it was really really wonderful, Dr. Sam. Really wonderful. Thank you so much for sharing your knowledge with us.
Thank you, Fernando. It's really, sharing is the most important pleasure in life. I'm not for the self-pleasure. I always try to share. And I think it's important to share what we know. And I think that I'm starting being a good teacher because I see that my followers are better than me now. So I feel like being have to improve myself. This is good.
Yeah, thank you. Oh, Baris is here also. Great.
Oh, great. I don't see him. But...
Yeah, Dr. Saban, let's go for some questions. Okay, I know you have other things to do, but let's go for some questions. Is that okay for you?
Sure, absolutely, yes. Pleasure.
Okay. First question here. Let me choose one here.
While you are looking for that, I would like just to remind, don't be disappointed if your first case doesn't work as well as you would like it to be. And go on, but remember that you cannot go directly from structure to preservation without revising some knowledge and some biomechanics.
All right, great. Okay, the first question here, Dr. Saban, some people are asking about, a lot of people actually are asking me about the books, your book, Body Structure, Roland Daniel, Peter Pahazi. How can they buy it, the third edition? Is there something?
Yeah. There are still some ones of the second edition, but not many ones. And the third will be issued, I think, soon on Amazon. Barish will be able to answer better than I'm doing. But I would like to, again, to repeat that without Barish, probably I would not be here today, because Barish was really the very first one to believe in the technique and he was very open-minded to do this. So I would like to thank him and to congratulate him again for that.
Yeah,
and
yeah.
For the book, he knows that on Amazon it will be possible very soon. The first edition is completely sold out. The second, I still have about 50, maybe 50 books. And the third one is probably this autumn. Probably.
This autumn, okay, great.
Yeah.
A lot of people asking. And I say that you guys, the four writers of the book, are a perfect combination, because you are the father of the preservation thing. Roland Daniel is the ambassador. Peter Paul, the anatomist, and Body Shakir is the one very skillful guy advertising and making it popular. So it's so great to see you for your guys together.
Yes, thank you very much. I do agree. I think the team is very important. It's what I always repeat. And without the team, nothing is possible. Believe me.
Yeah. So let's go for one question here. Dr. Saban, do you resect anything of superior lateral cartilage because enlargement of middle third?
Yes. There is the basic, and then there are the refinements. Sometimes you cannot preserve everything. Sometimes you have to remove the bones. We told that already. And sometimes you have to adapt the upper lateral cartilages to the width of the dorsal, because for two reasons. First, it can be too wide at the beginning and sometimes very strong cartilages. And second, when you are lowering, then they are, I don't know if you see my hand, but they are like this. When you lower, it becomes wider and rounder. So it improves the nasal valve that is here in the middle, but it widens a little bit the middle third. So sometimes it is what we want to achieve in narrow noses. Then when you lower the dorsum, you have perfect lines. But sometimes when you lower it, becomes too big. So then you have to adapt. The question is the upper part. Yes, upper part is really possible. Sometimes you have to shave. Sometimes you have to reshape. Sometimes you have even to divide from inside the upper part at the level of the upper part of the key area, the dorsal key area, in order to be able to make it thinner or to narrow the upper part. And then you can make stitches. If you are in open, it's easy. If you are in closed, it's a little bit more tricky. And secondly, let's consider the upper and the lower part. Upper part, I have just said that, wide, strong cartilage, you have to do something of the cartilage here, starting with shaving and then sometimes to divide the upper part. The lower part is different. It becomes wider because of the lowering. In this case, you can separate a little bit, divide a little bit the caudal part, the lower part of the upper lateral cartilages from the septum. So you are breaking the bridge at the part. And I like to say that the vasa segment. I heard that I am the father of the vasa segment. Vasa segment should be about 8 millimeters to 10 millimeters. If it is shorter, I mean, sometimes at 2-3 millimeters, then it broadens. And if you have to divide it, you have to get about 8 millimeters vasa segment. So you have to create a new W point at a higher point that allows for reducing the width here. And you can even resect part of the scroll at the lower part in order to narrow the middle vault. But these are refinements, but it's important to know that it exists and that it can be done.
Yeah.
Infertility. Plastические chirurgy. Da. I can answer. No, in Russian, not good enough. The management with the inferior turbinate. Okay, this is two different part of the answer. First is you have to check before surgery. You have to know before surgery the status of your inferior turbinates. So you should know before starting if you will have to perform something on the inferior turbinates, because patient needs to breathe after surgery. This is the first point. So intraoperatively, it's not the place for discussing about the inferior turbinates, but you have really to perform inferior turbinoplasty. There are different ways in order to improve the breathing of the patients. But this is pre-op. In post-op, intraoperatively, a bit late, you see that the patient, you have a narrow piriform aperture, because people are always talking about turbinates. But piriform aperture is an issue. And even in classic rhinoplasties, when you're performing the infracture, it can reduce. With the infracture, can reduce the piriform aperture. So preoperatively, in pre-op, you have to know the width of the piriform aperture. And sometimes you will need to resect the anterior part of the piriform aperture in order to widen it a little bit, or sometimes even to resect together with the piriform aperture the bone insertion of the inferior turbinate, so you are really able to widen the entry point of the nasal fossa.
Okay, great. Here a question: is there any possibility to perform preservation in high septal deviations?
Yes, of course. It's I know many people say, "Oh, it's not possible." It's not only it's possible, but it's a very good indication, because you can really adapt your dorsum on the septum, and then you can change. It depends on what we call high deviation. It can be the septum just below the vault, or it can be posterior one. I'm talking mainly about the cartilaginous quadrangular cartilage. Yes, I'm doing this most of the time. Most of the time, yes.
All right. And when you do that, Professor Saban, do you sometimes switch from high septal to low septal, or can you deal with that even with high septal?
No. You have always to go from depth to surface. So if you have to do a septoplasty or even a difficult septoplasty, you have to start with a septoplasty. And then what we have done on the septoplasty will give you the answer to the question, can I also perform a high strip or just changing the septum with the low strip, Cottle technique. Generally, when it's a difficult septoplasty, you have really to perform like a Cottle, swinging door and lowering, making straight. Because if you cut posteriorly, inferiorly, and then superiorly, the septum is completely floating, so you have no control of the future. So better to keep at least attached upward, and then you move downward and it gives you the possibility to do that. Thank you very much for the question, because it gives me the opportunity to talk about that 30 seconds, if you'll allow me.
Sure.
My article was high strip. You know why? Because even if I doing also Cottle since 30 years, I could not in one paper talking about Cottle, high strip, and everything. So we had to decide, and Ron Daniel told me, Yves, let's do something easy to understand, easy to perform. So let's start with the high strip. And it is what we did. You cannot introduce all the techniques directly. The second thing is Cottle. I have not talked about Cottle and in the States, but the story is that you could not even talk about Cottle. The name of Cottle was completely forbidden to say in the United States. So at the moment you say you are performing Cottle technique, you are dead. So we could not start with a paper talking about this kind of surgery. I mean, Cottle's philosophy. But it is very important, and it is what we nowadays people are calling low strip, but low strip is Cottle. Then there are variations, but
great. Okay. Is this true that the dissection of lateral key area will lead to instabilities?
Okay, generally we say the opposite. I say generally the question is it true that it stays stable? No, generally there is no instability, because you are not completely, if you preserve the mucosa, if you preserve the inner lining, just separating the lateral keystone area, like Goxel calls ballerina maneuver, it's safe. At the beginning, I was always afraid of having any collapse of the middle third cartilaginous, because it could make the lateral wall weaken. In practice, it does not. But you have to preserve the inner lining, not to destabilize completely the bony cartilaginous period.
Great. Right. One more question here, Dr. Leonardo. Do you have any decrease of tip projection or rotation when you preserve the ligaments without graft?
So there are different ways to answer to this question. If you are working on the nasal, and the way I'm doing, I perform a septal incision. I never perform an intercartilaginous incision. I stay always vertical on the midline, and there is no lateral incision, so there is no intercartilaginous. I repeat that because as I'm not performing any intercartilaginous incision on the lateral part, I'm not destabilizing nor the scroll, nor the cartilages, nor the attachment of the ligaments. So when you stay on the midline, then you perform superior corneal, and it's very easy to go from the caudal edge of the septum to the dorsum. So in this case, you are not touching the ligaments at all. So to answer the question, at the moment I have shown two cases where I didn't touch anything of the tip, the one teenager and one deviated nose. I didn't do anything, not even one undermine, nothing. And the tip projection after was the same than before. But of course, at the moment you are working on the ligaments, cutting the ligaments, or if you are destabilizing the insertion on close to the nasal spine, if you are performing difficult septoplasty, then you will have lowering of the tip, and you will have to give support to the tip, at least by reattaching the ligaments or to give support with struts. But Baris is much better than me on this point.
Okay. About osteotomies, people are asking something regarding the use of piezo, or which is the best device for osteotomy, in your opinion?
It's difficult because I'm not using piezo, and my friends who are using piezo are doing everything with piezo because they feel very happy with the piezo. So I think there is no choice. Maybe I'm old-fashioned guy, so I started with the classic osteotome, so I'm happy with the osteotomes. It is not expensive, it is easy to change, it is easy to perform. The thing is, you cannot reshape very nicely. So it's not really the answer to the question osteotomy, but Piezo allows you for very nice reshaping of the bony pyramid. While with the osteotomer of classic rasp, it's not as precise. It could be. But otherwise, I think it's up to you, depending on your experience, how you feel. Generally, what I like to say, because I tried piezo many times, once the guy was making installation of the piezo, I told him, I'm sorry, I have finished my procedure. Because just time to install the piezo, I had finished my rhinoplasty. So just up to the surgeon to decide.
Okay. Some people are asking here about inverted V deformity in preservation rhinoplasty. If you can have it, and if you have it, how do you treat it?
Frankly, I don't remember having one case like this, and I have done many ones. If there is an inverted V, first, I would like to say first, it could not happen because when you are lowering, then you are pressing the upper lats laterally. They're becoming more convex. So even if there was like laterally a little bit open, natural open roof deformity or inverted V deformity, then just by lowering, giving strength to the upper lats is filling the gap, and then the inverted V is disappearing. But doing normally without complete separation, I mean, if you are not completely performing a disarticulation between the cartilaginous vault and the bony vault, there should not be any no inverted V.
Do you think, Dr. Saban, it should happen if you preserve just the cartilage? In some cases, you have to do some camouflage when you remove the S-shaped dorsal in a regular way. You remove the bone cap and you preserve just the cartilage. Do you think in some cases you can have to camouflage that key area?
Sure, absolutely. This is a very good question. At the moment you are removing bone, you have to deal with the bones in the classic way. I mean, this is not a specificity of the preservation. You have the same problems than with the classic or resection or structure technique, and then you will have to adapt this kind of camouflage. I like using not dice cartilage that is too big, on my opinion. I like using not paste because paste is sometimes more difficult. I like using scales like Mirosh Kovacic described. I'm making like fish scales. I'm doing this, and I like putting this because it stays very well. It lasts, and there is no problem. But of course, to answer the question, yes, you have many time to do that.
Right, and there is some people asking. This is not the first time people ask me, and I'm gonna pass the question for you. Jose Carlos technique is a wonderful.
I answered already.
Yeah.
I said in my talk. Yes. What about Jose Carlos Neves technique? Yesterday he was presenting this on the European Academy webinar. I think it's very clever, and it answers, I would like to say, most of the issues we could have without this kind of technique. So I think it's very clever, not that easy to perform, because you have really to make a nice design and a cut up of the cartilage. But anyway, I think it's very good, and I think it will have a great future.
Okay. And one of the last questions here. A lot of people have doubts about the resection of the bone perpendicular plate. How do you do that? With which kind of instrument?
Okay. Perpendicular plate, I have done 10,000 septoplasties, so it's not an issue. If you are not pulling like an animal on the perpendicular plate, it's difficult to have issues. Generally, if you have Ferreira would tell you that there is no bony perpendicular plate under the bone, under the key area. I think it's not completely my experience. But to answer the question, if you have a perpendicular plate that is too low, I mean, going too in the direction of the tip downward, you should remove at least a small part. The instrument I'm using is basically the endonasal veil black Tesla forceps 3 mm that allows me just to remove this piece, and it works very well, and I have no problem with that. But you can use different kinds of instruments. You can use osteotome, you can use piezo, you can use a bone ranger. But I like this kind of process because it is really done for very precise and deep procedures.
Okay. All right. I know there are many other questions, Professor Saban, but also know that you have a limited time. You have another meeting after here. And so I just want to thank you for your time and for being such a nice person and such an amazing surgeon, and which is an example for everybody from beginners to masters because of your way of being, and we can see that it's very genuine. And I just have to thank you and say that you're an example for everybody. Thank you so much.
Thank you very much, Fernando. Thank you for this kind word. Thank you so much. And congratulations.
Thank you. All right, Professor Saban, so thank you. If you want to leave and do your things, I know you have another meeting after here. I'm going to stay a little bit more with people here just to answer some questions, okay? Thank you, Professor Saban.
Thank you so much.
Thank you very much. All right, guys. I know there are many questions. I'm sorry for not answering everybody, but Professor Saban has another meeting and he has to prepare himself for another meeting. So I'd like to thank you all. Okay, these last weeks has been wonderful for us. Okay, wonderful for us because we're learning a lot from everybody. We're learning a lot from webinars, from live talks, and this kind of unique opportunities we're having because of this pandemic, right? So there are good things there are good points in every situation, not just bad points. So just like to thank you, and also thank you a lot for participating and sending the application form for our online rhinoplasty mentoring. We received a lot of forms. Okay, I'm sorry I'm not answering you guys so quickly because I promised that I would answer personally. Okay, and I'm doing that. All right, I'm not sleeping so much. I'm answering one by one. But we have more than almost 300 until now. So I have to talk to you all in person. Okay, so I just ask you a little bit patient because I'm gonna do that. All right, I'm gonna talk to you guys and answer all your doubts or your questions about our mentoring program. And thank you so much for all your support, all your for everything. Okay, for trusting on our work, trusting in our lives. And thank you so much. Graças a todos. Obrigado a todos. Mais uma live excelente aí com o mestre e professor Saban. Tá bom? Então, a próxima, the next one, tomorrow, we're going to do a live in Portuguese and Spanish with a friend in Mexico. And it's going to be at night, okay? At night. So people from Mexico and Latin America and Brazil are going to be, it's a better time for everybody, okay? And on Saturday also we have another live, but it's I'm gonna check and post it on Instagram, okay? I think it's 1 or 2 p.m. So stay tuned, stay watching us because we'll have some other lives very interesting, both in Portuguese and also in English, and we can learn more on these days. All right, thank you so much. So see you tomorrow.